This is Chris A. Smith. I'd like to give you a lecture on selective approaches to mesial temporal lobe epilepsy. I'd like to thank my co-author, Alexander Whiting, for helping to prepare this. This is a topic that I've been passionate about for my entire career, for over 20 years, doing epilepsy surgery. The main focus is to do this in the most minimally invasive way possible with the least possible neurocognitive consequences to the patient, but still allowing the best possible chance of curing their epilepsy. So the key concepts are that the selective amygdala hippocampectomy appears to be as effective in terms of seizure outcomes as traditional anterior temporal lobectomy in patients with mesial temporal lobe epilepsy. There are multiple approaches which have been published and are used around the world for this surgery. However, I would like to focus in and give you a good argument that the subtemporal approach is the favored approach for multiple reasons. So we'll spend a lot of time talking about the reasoning behind a subtemporal approach for the mesial temporal resection. So it's interesting that Dr. Niemeyer, way back in 1958, first described the amygdala hippocampectomy as a way to treat epilepsy. It did not gain great favor at that time because of the difficulty without an operative microscope and the lack of really good imaging guidance systems or anything like that in that day, more than 60 years ago. But it was really when Dr. Yassergill published the Transylvian approach that it gained some popularity. And he described it for resecting tumors as well as for epilepsy, and it did gain a considerable following after this publication in 1982. And he was obviously a master surgeon and really invented the micro neurosurgical approaches for many things. But the subtemporal approach was first described by Dr. Horry in 1993, and again, it was a small paper, didn't really gain a lot of traction. But we kind of discovered this and then reinvented minimally invasive approach utilizing the subtemporal axis. So this is a coronal diagram that gives us the views of several different ways of getting to the hippocampus from the lateral temporal lobe. And as you can see, the more traditional way of Dr. Yassergill, the Transylvian approach, affords a corridor that many neurosurgeons are comfortable with. It involves going through the Sylvian fissure, and the blood vessels there are at risk, and that's the major disadvantage of this procedure. But another disadvantage is that you do have to go through the temporal stem, and you end up disconnecting a lot of the lateral temporal lobe that you're sparing, or attempting to spare from a neurocognitive standpoint by going this route. Whereas the transsulcal approach is a little bit easier than the Transylvian approach as far as not dealing with the major middle cerebral artery branches and has less of a stroke risk. That was the major problem with the Transylvian approach, is when they looked at it critically, there were many patients that had microinfarctions just from messing with the vasculature in the region, and that's pretty much avoided with a transsulcal approach, or even more so by avoiding the vessels of the sulcus altogether by doing a transgyral approach. Dr. Olivier in Canada definitely preferred the transgyral approach. It's an approach that's fairly easy and straightforward, especially for non-vascular neurosurgeons, and you get to direct access in a comfortable fashion to the hippocampus from lateral. But again, you do disrupt and destroy tissue in the lateral temporal lobe as a way to get there. The last one is the subtemporal approach on the bottom, which is more challenging because you come from underneath and there requires relaxation of the brain, and it's not a straight shot. You have to go under and then up and over to get to the hippocampus. But as you can see, by coming in through the collateral sulcus, you spare all of the lateral temporal lobe, all of the visual fibers, all of the temporal stem, the uncinate fasciculus, all of the connections to the frontal lobe. And so from a neurocognitive standpoint, I believe, and I've shown data to support this, that it is indeed superior as far as the neurocognitive outcome goes, and is the least destructive, least cognitively impairing approach to get to the hippocampus. So there are no prospective trials comparing the different approaches, so it's all based on published series of the different approaches and comparing them to each other. There are multiple retrospective series, however, that do demonstrate comparable seizure outcomes, and typically the number is around 70%. If you have a patient with mesial temporal lobe onset epilepsy or typical temporal lobe epilepsy, then it really doesn't matter how much of the temporal lobe you take out, except for a complete resection of the hippocampus. And there's really no evidence that taking out lateral temporal lobe structures increases the seizure-free outcomes any more than just a good and complete amygdala hippocampectomy. So my belief is, and I believe our evidence and our series bears this out, that just removing the hippocampus is the most important thing, and doing it in the least invasive way possible allows the best cognitive outcome and also the least trauma and recovery for the patient. So this is my technique. This is where the incision is really quite small. It just goes over the pinna of the ear from the tragus, and it's a small window is required. This approach allows you to reflect the ear downward. I utilize fish hooks and C-clamps attached to the Mesial to just retract the skin down. It gives you a nice low-profile approach. The incision in the temporalis muscle is essentially vertical, and take advantage of the fact that the middle fossa goes up as you go from anterior to posterior and allows you to be right on the floor. I used to make the incision straight vertical up in front of the ear, but found that this little curve over the ear allows the flattest approach the easiest way through the smallest incision, and I don't fight as much of the temporalis muscle anymore. It does require a good anesthesiologist. We have the patient's head slightly down, and I typically use a little bit of reverse Trendelenburg to have the whole body up, and that helps the brain to relax, and you do need mannitol and dexamethasone and a good anesthetic to do this well without struggling. But it's really about making the bone opening right on the floor of the middle fossa, and it doesn't help to go any higher. It really doesn't. I don't use any retractors in this operation, although I did at the beginning. I've found that by coming up underneath the temporal lobe above the dura, just gradually letting CSF out, that it eventually completely relaxes to allow me to go from underneath up to the amygdala and hippocampus. This is the principle called the keyhole principle for me, where you angle the patient by rotating the bed anterior, posterior, and inferior as you go from front to back. And the first part of the operation is the arrow to the front to the amygdala. And by removing the amygdala, eventually the temporal horn gets exposed and all the CSF comes out of the ventricle and allows for even more brain relaxation, allowing for the hippocampus to be visualized through the ventricle opening in the front, and then gradually extending that from front to back while protecting the choroid plexus with cottonoids, and by going along the choroidal fissure and resecting the hippocampus in block. The body comes out in block, and the tail and the amygdala come out through suction utilizing the microtip of the ultrasonic aspirator. This is a typical appearance of a postoperative amygdala hippocampectomy done through this subtemporal approach. I'm quite proud of this because, as you can see, this is 1 day post-op. There's absolutely no trauma to the temporal lobe. The temporal stem is completely intact. The entire hippocampus has been removed with really no evidence of a tract to get there, and this is obviously the goal. So in conclusion, I do believe that the subtemporal approach offers the best way to get at the amygdala and hippocampus for the least invasive removal, to allow only removal of the epileptogenic tissue without consequences to any of the rest of the function of the temporal lobe. Because you come in from below, the optic tracts and radiations are not at risk, and our series points out only a 1% chance of any visual field deficit, which is much lower than reported in anterior temporal lobectomies or any of the other lateral approaches to the amygdala hippocampectomy, and it is actually even less than laser ablation approach. So it is challenging and a little bit of a learning curve, but it can be done very safely and successfully and has a small incision to heal from for the patient. Thank you very much.